Vascular rings, pulmonary artery slings, and associated anomalies. The term vascular ring refers to any congenital vascular anomaly of the aortic arch complex that has the potential to lead tracheoesophageal compression. A pulmonary artery sling is similar but distinct lesion where the left PA originates from the right PA instead of the main PA, encircling the distal trachea before entering the hilum of the left lung, resulting in the tracheal compression. The PA sling is often associated with complete tracheal ring. 6 pair of aortic arches connect primitive ventricle to the dorsal aorta in the embryonic vascular development. The typical aortic arch anatomy depends on the appropriate preservation and deletion of the particular segment of the embryonic aortic arches. Specifically, the first and second and the fifth arches regress. Third pair of arches from the bilateral carotid arteries. Most of the right fourth arches involutes, leaving the fourth arch to become the usual left-sided aortic arch. The ventral portion of the sixth arch interacts with the lung bud to form PA. The dorsal right sixth arch disappears where the dorsal left sixth arch develops into the usual left-sided ductus arteriosus. Given this complex sequence, it is expected that vascular rings and the PA slings result from abnormalities in this process, leading to symptomatic compression of the nearby structures, mainly the trachea and the esophagus. The double aortic arch. If both the embryonic right and left fourth arches persist, a double aortic arch forms, creating a complex vascular ring. Both the right and left aortic arches join ascending aorta to the descending aorta, forming the ring encircling the esophagus and the trachea, causing the compression of these structures. Of note, the aortic arch sidedness is determined by the relation to the trachea. In double aortic arch, the right aortic arch travels right of the trachea and posterior to the esophagus, giving rise to the right common carotid and the right subclavian arteries, while the left aortic arch is an unusual position anterior and left of the trachea, giving rise to the left common carotid and left subclavian arteries. It is essential to determine which of the aortic arch is dominant for the surgical planning and vascular ring division. In 80% of the cases of the double aortic arch, the right aortic arch is dominant in 10% and the left arch is dominant, and the 10% of the arches are balanced and are equal in size. The right aortic arch. Anatomically, the right aortic arch travels the right aortic arch travels to the right trachea and courses the posterior to esophagus to join the descending aorta. The right aortic arch results from the persistence of the right fourth embryonic aortic arch and involution of the left arch. There are two common types of the complete vascular rings that may occur in the setting of the RAA. The right aortic arch with aberrant left subclavian and left ligamentum arteriosum. The proximal portion of the RAA sequentially give rise to the left common carotid and right common carotid and right subclavian arteries. An aberrant retroesophageal left subclavian arises from the proximal descending aorta with or without associated aneurysmal dilation at its origin, known as the Comrell's diverticulum, and courses leftward behind the esophagus. The vascular ring is completed by the left-sided ligamentum extending from the PA to the proximal descending aorta and encircling the trachea and esophagus. RAA with mirror image branching and the left ligamentum to descending aorta. In the vascular ring, the RAA gives rise to the left innominate artery, branches into the left common carotid and left subclavian artery, the right common carotid and the right subclavian artery. If the left-sided ligamentum forms between the PA and the descending aorta, a complete vascular ring is formed. Conversely, it is ligamentum that connects PA to the left innominate artery. More commonly, a ring is not formed and no compression occurs. In a PA sling, the PA abnormality arises from the right PA instead of the main PA. The left PA courses between the trachea esophagus as it travels to the hilum of the left lung. This forms a sling around the distal trachea, leading to compression, and often this anomaly is associated with a complete cartilaginous tracheal ring, the ring sling complex, where the distal posterior membranous trachea is replaced by circumferential rings. The age and symptom of presentation depends on the type of vascular anomaly and severity of the tracheoesophageal compression. The children often present with the symptom of first few months of life. The tracheobronchial compression will lead to symptoms of stridor, steel bar, cough, and recurrent respiratory infection. Important investigations is chest X-ray, barium esophagogram, CT, MRI, echocardiogram, bronchoscopy. All the patients with DA or PS sling should undergo surgical repair regardless of the presence of the symptoms due to high likelihood of developing esophageal and tracheal scarring in future. For the other types of vascular sling, the decision to pursue surgery is based on the family preoperatively and counsel them that symptoms may persist. Double aortic arch is essential to identify the preoperative imaging with the dominant arch, and the approach is via muscle-sparing thoracotomy of the third or fourth intercostal space. The right aortic arch vascular rings are approached via the left muscle-sparing thoracotomy. The PS rings are approached via the median sternotomy with a cardiac pulmonary bypass. The vascular rings have a safe operation. The most important complication counsel families of persistence of recurrence following the surgery. Less common complications are related to dissection, injury of nearby structures, recurrent laryngeal nerve leading to vocal paralysis, thoracic duct causing the postoperative chylothorax. Similarly, the outcomes of the PA slide repair in the tracheal plasty and excellent with low mortality. It is important to monitor these patients with recurrent tracheal stenosis requiring reintervention such as reoperation and endoscopic dilation. Thank you.